Hello, this is Kim Youngjae from a Korea Dental Hospital. Today I will talk about implant design. Even if you search the internet or YouTube, there are no doctors who accurately understand and explain implant design. This is because there are not many dentists. The implant that Carl Misch developed is called the BioHorizon implant. But actually it wasn't developed by Carl Misch. As far as I know, it was developed by a professor in the material science department at the University of Alabama and announced under Carl Misch's name. I also went to the University of Alabama and participated in implant design. Recently, there is an American distribution company called Henry Schein. They hold online lectures and webinars there. Aside from a professor who lectured about implant design, I think there hasn't been a seminar that details which implants are good, how implants are designed, and what characteristics each design has. Since I have been involved in implant design for about years, I will explain how slock implants have developed. Next, I'd like to talk about how we've created better implants. So to get to the conclusion first, I wrote, implant design is decisive factor in success of implant dentistry, which means that the design of the implant is a decisive factor. However, I have also thought about this. Initially, there was a lot of discussion about the materials used in implants. So in the beginning, we thought that the material was important, and in the early days, there were many issues related to the implant materials. What I mean is, historically, during the Egyptian period, seashells were used. There are papers that mention the use of seashells, and then there are stories about using silver, gold, and stainless steel, and later synthetic sapphire was also used. Many different materials were used like that, but eventually, with the emergence of titanium, implants began to be made primarily from titanium. So I'll talk a little more about titanium and then return to the topic of implant design. There are pure titanium and alloy titanium. They are explained by dividing into grade 1, 2, 3, and 4, and grade 5 is mostly classified as an alloy. So now, the first product of Brandmark implants used grade 1. I still remember that it was about 28 years ago, and when using Brandmark implant products, you can see that the hex on the top deforms even with a little force when inserting the implant with ratcheting. It was very weak, but it adhered well. Then mechanical failure started to appear. As a result, after using grade 2 and grade 3, most companies are now using grade 4. So companies like Nobel Implants, Astra Implants, and 3i Implants use grade 4, and we also use grade 4. So it has become a trend to use mostly grade 4, but the problem that arises from using grade 4 is that fixture fractures occur frequently. To overcome this, American companies like Zimmer Implants and BioHorizons Implants use grade 5. The reason is simple. The US has a class action lawsuit system. So if implants keep breaking and a class action lawsuit occurs, the company usually goes bankrupt after paying compensation. So it's okay if the implant doesn't adhere, but if it breaks, it becomes subject to a recall. Right? That's why representative companies in the US like Zimmer Implants and BioHorizons Implants use grade 5 alloy. It's amazing. Why is it amazing? Because grade 5 alloy is made up of 6% aluminum and 4% beryllium. This means 10% is carcinogenic substances. And since the remaining 90% is titanium, it generally has poor biocompatibility and doesn't adhere well. So, Zimmer implants usually have HA coating. There are various opinions about BioHorizons implants. Even though BioHorizons implants don't adhere well, there are still places that use them. In Korea, they have almost been ousted, BioHorizons implants. I've also gone through a lot of hardships. Still, it seems that it is still widely used in the United States. As far as I know, a large orthopedic group company has acquired BioHorizons implants and is manufacturing them. And I think that company has some power, which is why they continue to sell. And Straumann implants are also famous. In terms of Straumann implants and ITI implants, they use a titanium zirconium alloy called Roxolid. We try to use this as well, but it is not imported in the country. Domestic companies also made a lot of efforts to try using rock solid, but since it cannot be imported, they probably gave up and are now mainly using grade 4. There are companies that use titanium from Carpenter, and there is an annealing company called Fort Wayne. There are places that use zirconia from that company. It sticks well. It's about grade 3. The weaker it is, the better it sticks. It tends to break more easily, making it difficult to use. So if you look closely, Zimmer Implants and BioHorizons Implants are American companies. So they need to be careful about mechanical failure. Keystone is probably a US company, but anyway, it seems that the European companies are following biocompatibility a bit more. That's their characteristic. When looking at the alloy as 100, grade 4 is about 64% and rock solid is 92%. Rock solid contains zirconia, so it is very brittle. Brittleness. What that means is that it breaks easily under impact. So it doesn't seem helpful, but it looks good because it's done by a famous company called Straumann Implants. The company power is significant. Company power is good. Currently, most are using grade 4, and I know that a well-known company in Korea using grade 5 is IBS Implants, but it seems they are struggling because their implants don't adhere well. So places like MyQ Implants emphasize that they use only grade 4. As a result, hospitals selling IBS implants have reached a situation where they are marketing aggressively. This is not very good sales, but it can't be helped. So that's what it was. Our slock also started with grade 5 at first. This is the shape of the old S-lock. There were many difficulties in using this. The success rate of its implantation was about 90%. That means 10% was missing. The low success rate resulted in poor business performance. So we struggled a lot. Since switching to grade 4, there have been no complaints about it not sticking. Grade 5 could only use RBM surface treatment, so we couldn't use SLA surface treatment technology. But grade 4 is better with SLA technology than RBM, so we are doing surface treatment with SLA. And recently, our next development products are SLX, TLX, and since only locking types have come out, there has been some preference among consumers. The Torx and screw types use the same methods as the existing regular implants, so there's no need to learn anything new. And since it has become digital, it seems to be well received. However, our company still sells this more because it's convenient and has a good prognosis. However, since it's unfamiliar, you may find it difficult to use. This side is a screw type, so generally the learning curve is short. You can learn quickly. So when selling this Torx Plus implant overseas or to nearby places, we mainly explain this. Everything is grade 4. Grade 4 means it bonds well and uses SLA surface treatment. Next, I will talk about implant design, occlusal force, and the bioreactive balances of bone tissue. You should now understand the implant material that I have discussed so far, and next I will divide the discussion into two parts: macro design and micro design of the implant. Macro design is simpler than you think. It can be explained mainly in 4 key categories: implant outline feature, thread design, the shape of the crestal module, and the abutment connection method. Micro design pertains to surface issues. The fact that we perform SLA itself creates micro irregularity. There is a value called RA. It uses the expression roughness average. So they talk about values like 1.5 to 2.53. It's a difference between whether the roughness is 2 microns or 3 microns, and the larger this number, the better it adheres. The paper says not to exceed 1.5. It is written that when it goes over 1.5 microns, there is a significant increase in secondary implantitis when periimplantitis occurs. So the paper recommends around 1.5. The roughness of domestic implants is mostly between 2.5 and 3. So once it starts to dissolve, inflammation around it becomes immense and the bones dissolve. The surface treatment is excessive. I think it's because there is a belief that it should adhere well. So I think it's like this. In advanced countries, specialists primarily perform implant surgeries, so their adhesion skills are not lacking. In Korea, since mostly private practitioners are performing surgeries, they seem to have difficulties when initially adhering. They also strive to use clean implants. So I think there might be that kind of nuance. And in the case of microdesign, it's surface treatment. Next, we have bioactive material coating, and a representative example is HF coating. So let's take a look. This is the surface treatment state of the slock implant. So it's SLA. After sanding, we mix sulfuric acid and hydrochloric acid for acid treatment, and it turns into a crater shape like this. Details that look like basalt formed after an explosion appear. Not satisfied with this, we process it one more time. You can see that this hole is 1 micron, one space. I know this one space is 1 micron. So, this is 1 micron. Because it's one hole, if you calculate this, it's about 1.5 microns. The RA value is about 1.5. This inside is the RA value. As I mentioned earlier, the roughness value here is 1.5 microns, and we have stuck 20 nanometer particles all over the surface. So this is called nano SLA, but there is no separate nano SLA permit. So the way it's expressed is, it's SLA, but it has a nanostructure. It's the same for us and for Straumann implants. That's because the only places doing nano SLA are us and Straumann implants. The Roxolid from Straumann implants doesn't adhere well. Since zirconia is included, it doesn't stick well regardless. So it's said that it's treated at the nano level, but even if it's SLA, it doesn't adhere well. They say it's SLA, but with 15% zirconia, it's not easy to become SLA. They adopted a nanostructure to try to overcome that, but if you look at the paper, you can see that it's not uniform and that this structure is sparse. If you look at our S-Lock, the nanostructure is uniformly and accurately reproduced on all surfaces. This is quite important. You don't often see implants like this. So it's a 20 nanometer crystalline TiO2. This is not something that was created by coating, but it's a modification of the titanium oxide film that forms naturally. In my opinion, this is the only way in the world and the only surface. It's really impressive. There probably isn't a company that makes a surface like this. We struggled for about 5 years to develop this. I think we kept repeating in various ways. They say that every invention requires a bit of coincidence, but that coincidence should also have direction. Following the advice of the material science professor, we developed with direction, and as a result, we were able to consistently achieve uniform and steady results. So I believe this is the only implant that has a uniform nanosurface. So, in fact, nanoslay is our second. The Straumann implant is the first. However, with regards to results or quality, we can't help but say we are the best in the world, and we have clear photos to prove it. So I think this is pretty good. Last year, I implanted 2,023 implants. We count this number at our hospital. We write down all the implant numbers along with the patient names. I report 100% of it for tax purposes. Tax reporting is done 100%. When I counted, I found that 58 were missing. Calculating, the probability of missing is about 0.27%. It's about 2.7%. So the success rate is about 97. That's a very high number. Right now. They say about 99% of fixtures are attached to the bone, but there are actually no such statistics. Globally, the success rate is between 96% and 97%. The success rate usually falls between those numbers. That's the case for major companies. Minor companies often tweak their statistics and interpret them subjectively, so it's a situation that's hard to gauge. But to be honest, I really don't know. I see a lot of difficult cases. I perform a lot of bone grafts too. The 97% success rate is probably due to the nanocellular surface design. That's what I believe. Macro design and micro design create the characteristics of the implant. Because they all use titanium, the grade may differ slightly, but they all use the same titanium. There are only 3 companies in the world that manufacture titanium. Because of the Carpenter Company in the United States, next is the German company Zapp. The next one is in China. It seems that only those companies have furnaces that can melt titanium. I heard there are only 3 in the world, globally. However, most of the fixtures in Korea are mainly from the American company Carpenter. I guess other places are almost similar. Then for abutments, we mainly use those from the German company Zapp. So the materials are the same. In a world with countless types of implants, the materials are only American and German. It's a bit ironic, isn't it? Ultimately, the characteristics of an implant are determined by its design and surface treatment. These 2 aspects, macro design and micro design, determine the characteristics of the implant. They also influence osseointegration. Then the implant design transmits, distributes, and absorbs occlusal loads to the surrounding bone. The bone around the implant must achieve a bioreactive balance for the implant to remain intact. This is because the bone does not remain static. New bone forms, matures, and gets absorbed, and so the characteristics determined by the implant's micro and macro design ultimately affect the bone surrounding the implant. Thus, this influences whether the implant lasts a long time, comes out quickly, or experiences bone resorption. Crestal bone loss can occur as well. When the bone is well maintained, it is functional and aesthetic. How do you assess long-term results? The first is mechanical failure. This includes scenarios where the implant breaks, the screw loosens, or the abutment breaks. The material is weak or the design is wrong, which creates a vulnerable spot. Secondly, crestal bone loss occurs around the implant, causing the bone around the implant to dissolve. If the bioreactive balance is not established, it breaks down. In the end, the bone around the implant dissolves, leading to failure. These are the 2 factors to consider. All you need to do is think about this well. This lecture is about implant design, so we will look at how the overall shape, the shape of the threads, the shape of the crestal module, and the shape of the abutment connection affect the differences in implants. This mainly concerns macro design. Regarding micro design, it seems that the conclusion has almost been reached. The conclusion is that SLA is good, and there are only 2 companies in the world with a nanostructure like ours. Among them, our nano SLA structure is quite distinctive. So, if I talk about 4 things regarding macro design, it might help you understand the implants. First, let me talk about the overall appearance. The overall appearance is the first point. It's important. Very important. The outline design consists of about 5 types. One is cylindrical, the second is tapered. There is also a straight tapered shape where the top is tapered and the bottom has a straight shape. The outline design of our S-lock is dual tapered. The appearance of the implant is really important. Even now, there are many people who like the spherical design of S-lock. There are people who request spherical designs to be made because it has been around for a while. The spherical design was difficult to attach, but once it was attached, there were no problems. The bottom part had a large form design. If the apex of the implant is sharp, it's easier to insert, right? The sphere is not sharp, so it was difficult to implant, but it had better durability. So there are still people searching for spherical designs. In terms of surgery, primary stability is the most important. No matter what anyone says, primary stability is the most important. Those who have used Bicon implants say otherwise. But that's absolutely not true. Of course, the bone needs to be good for placing Bicon implants. It's left soaking because there is no primary stability. People with lower bone repair and healing capacity find it difficult to use Bicon implants. So consider those things. We will look at surgery from the perspective of primary stability. From the left, we have cylindrical, tapered, straight, tapered straight, and dual taper. The surface macro design affects the initial bone healing response, and the overall shape macro design determines the success or failure of implant treatment along with occlusion. This means that the shape plays a very important role. Even now, we categorize them based on shape apart from the threads. For example, there is the ITI implant. The ITI implant also has various shapes. Most domestic implants are copies of Astra implants. The shapes are not different. Most domestic implants use the same materials as Astra implants, with only the threads and abutment connections made differently. So we should think about this carefully. The early implants were cylindrical in shape. That's because this shape is the easiest to machine. You only need to make the threads, so the cylindrical shape is just slightly pointed at the end. Therefore, the industrial standard was cylindrical, so they made them that way in the beginning. You'll see this is Mark IV. This is an implant that has been sold until recently, and there has been almost no design change. It doesn't seem to be from the early implants. It also seems like a copy. Anyway, this is the Mark IV implant, and it looks like it has double threads. It's difficult to place, so they seem to have made the threads in 2 rows to insert it quickly. So the shape is neat. This is also a good design. It's just a bit hard to insert. What happens after you place it? There tends to be some loosening. The reason is that the tapered shape increases pressure the more you insert it, while with the straight shape you can't insert the implant right in the center. So it would move a bit and rotate as it goes in, then the hole gets larger. So the initial stability is not good. And this is probably known as the core vent implant. Now it's called Zimmer implant. Before that, when it was Dentsply implant, it was the Paragon implant. Before that, when Dr. Neisnick was selling it, it was called core vent. It made holes like this. This is where the bone fills in. Inside, bone does grow. When I removed what was done before, there was bone inside. The shape of this is also straight. In the beginning, they all made it like this. I'm sorry. Brandmark implants are also unique. They still make them like this. So, there's a stubbornness and pride involved. Earlier, I mentioned that the cylindrical shape cannot be inserted directly in the center, and if it's inserted crookedly, eventually the hole gets larger. Initial stability is not good. So, I thought that if I made a tapered implant, initial stability would be much better, and that's why it was made in a tapered shape. Tapered. So, primary stability increases. Thanks to that, implants are performed well in sites with poor bone quality. But what happens in hard bone? If it gets stuck while being inserted, it becomes a situation where you can't insert or remove it. However, the probability of pressure bone necrosis continues to increase. Is this perhaps the Superline implant in Korea? Dentium implant? I think there have been quite a few people who have struggled with situations where they couldn't insert or remove it while trying to place it. So, while the wedge shape has good initial stability, it is harder to place. Earlier, the cylindrical type is good for placement, but eventually, screw loosening occurs, so it becomes difficult. In the past, there were things like this. What was this again? I still can't remember. I remember it as an early version of the Camlog implant. The Camlog implant came out like this. Then, since this didn't work, it seems to have changed to screw. This is called TPS, and the plasma coating was applied to the surface. When titanium is melted at a high temperature and sprayed, it sticks to the surface. There were also many cases of HA coating. In the early days, there were many versions like this. Rather than making screws, there were many implants that were made by roughly cutting. All of these were inserted by tapping. Places like Bicon implants are like that. This initially adheres well. In the beginning, it adheres well, but it doesn't last long because when occlusal forces are applied from above, the surfaces hit each other, causing shear force. This is the worst thing. So it often came off. Then they started making things in this shape. I thought about whether it would be good to make it in a tapered type, and as I started making a tapered type, the initial fixation improved a lot, so I made it like this. The problem with this type is that it cannot create many threads at the bottom. Therefore, the surface area of the implant does not increase much. To solve that problem, it became elongated. But what about the short ones? Short ones cannot be made in a tapered shape. If it is this long, at least the diameter will be 15 mm or 18. While making it tapered in this length is acceptable, there is no way to make the short one in a tapered type. These products are sold, and then thoughts change. So I wonder if we could do it this way. The surface area has become too small. The surface area is too little. So I think, how about making it straight on top and tapered on the bottom? Many products like this come out. The feeling is easy, and bone necrosis decreases as well as pressure bone necrosis. Anyway, since the shape on the bottom is tapered, the reduction in surface area cannot be helped. That's why implants of this style continue to come out. Tapered at the bottom and straight at the top. These things keep coming out. This is also the case, right? This is probably an Alpha Bio implant or an MSI implant. In that category, many implants of this shape come out. But this one has no threads on the top. It broke, so they disappeared. There is a micro groove, because if it gets thinner, it all breaks. So they remove the threads. Think about it logically. There is a screw pitch at the bottom. Then the screw pitch on the top should be the same. But this is not a screw. So we think that implants shouldn't be designed like this. The same goes for this part as well. The screw pitch on the top and bottom are different. I don't know why. There are even things like this. There was one called the Saigon implant, which had the bottom widened. The Saigon implant failed completely. But at that time it was sensational, claiming that it changed the landscape of implants, and it was sold very expensively. It almost all went bankrupt after coming into the country and disappeared. If you think about it, the Straumann implant is the same. There are types like this and straight types as well. I heard that this is used a lot. Someone in Youngjae said that once this sticks, it's hard to remove. They seemed very satisfied, but it's tough on the mind. There are things like this, and there are zirconia implants, and there are others. Recently, there's a new style of implant called BLX. It's somewhat similar in design to TLX and SLX. However, the BLX is not a unique design of Straumann implants. Similar designs had already come out in the US. Straumann implants copied that. So they keep exchanging back and forth. Then a type comes out where the top is tapered and the bottom is straight. A representative example is the Astra implant. The Astra implant has this shape. The top shape of the implant is wide. So it has good dispersal of occlusal forces. And in the case of an extraction site, the space above is large at the extraction site, on the crestal side. That's a good thing. On the contrary, what should we do about the knife edge? When you implant such implants, GBR is almost always necessary because the threads are exposed outside. Then GBR has to be done. The failure rate is also high, and these factors continue to lead to the use of tapered types. On the contrary, this one has a small crestal module. This seems to be an Aidin implant. It is probably the product that came out of the United States. These are easy to implant. The design of implants has been evolving in this style. However, we are dual tapered. It's dual tapered. Where did this idea come from? About 3,000 years ago, pottery was discovered in Japan during the Neolithic period. They say this is Jomon pottery. It's Japanese pottery. It looks exactly like our slock, right? Many of the Jomon pottery pieces have preserved round shapes. This shape is said to be the most durable. Isn't that right? And there are biwa-shaped and seiform bronze swords. As you can see, it was early Bronze Age. Bronze comes before Iron Age. Iron Age. The Iron Age equestrian tribes end up conquering everything. There is a road of the steppe that, in the past, connected Mongolia to Europe, stretching all the way from Kazakhstan. It's all connected to the Tatars and Slavs. However, they were nomads, so they did not record history. And they keep moving, so there aren't many artifacts. Eventually, the Iron Civilization comes in, and the Bronze Age collapses. But this bronze is weak. I've heard that a lot of tin comes from Kyrgyzstan. If you mix 20% tin, you can create a bronze sword. So the bronze is very weak. Now, swords made of this bronze come out, but since the durability is weak, what do you think happens? It's here. It's in the shape of an S. So it's all about durability. This is a Chinese bronze G-shaped dagger, and the Korean one is a single piece. China makes the blade and then attaches it to the handle. Korea makes it all in one piece. The shape of Korea can be seen as one body, and when flipped, this side can be regarded as the fixture and this side as the abutment. So, the Korean bifurcated bronze sword is one body, while the Chinese one can be seen as two bodies. It seems they are distinguished like this between Korean and Chinese items. When artifacts are discovered, they are classified in that way. But anyway, the motivation for my implant proposal was these two things: the bifurcated bronze sword and Jomon pottery. So, the durability is extremely good. There hasn't been a single fixture fracture in 15 years. That's an amazing achievement. Still, not a single one. It transfers occlusal force well, and since the taper is in two parts, there are two anchorages. Even if one side passes through, the other side is relieved. If it passes here, it will relieve here also. Then another one gets caught. So this side is fixed only in one place, but this side has the tapered part in two places. So I think this is much more advantageous because the initial fixation is better. So it can be cancellous and also crestal. So I think it will be much more advantageous, and that's why I made it this way. This healing pattern is a little different. In areas that have been under pressure, oppositional bone graft occurs, and in areas where relief has happened, callus bone format develops. Let me explain. I can't say that a certain shape is absolutely good. How do you do it when performing an immediate implant? There is an extraction socket. When you put the implant there, the Astra type is much more advantageous. Why? The gap distance is a bit smaller. To overcome this problem, using a wider size implant is much more beneficial. Even now, after extraction, we are doing immediate implants with small implants. Especially in cases of teeth and 7, initial stability isn't achieved. So they wait after extraction and then proceed. However, if we use a wider implant, it's easier to perform immediate implants after extraction. You all worry about what to do if it fails. It's the same. If it fails, it usually comes out within a month, right? Just wait 2 more months or 3 months, and then you can do it again. In a way, it's very convenient. So I think it's right to actively proceed with the implants immediately after extraction. Knife edge is the opposite. Having a wide upper part is a bit difficult. So Astra Style's tapered straight type almost doesn't work. And you have to place it at least 1 millimeter downwards so that the crestal bone doesn't get resorbed. So in the end, you have no choice but to implant it deeply. In our case, like slock, even if you implant deeply, there is a post height. There are various abutment post heights, right? So it's convenient. For knife edge, if you use tapered or straight types like before, the outer, labial, or buccal sides all burst and can't handle it. You have to do GBR everywhere. But that's not an easy task. So you can think of it this way. In the end, compare the dual tapered type with ours and the others carefully. Then it will become a little clearer. So now how to implant that is important. These are example photos of implants by size. If the wide implant at the bottom is not drilled properly, it cannot be placed. Most people think it should be easy to implant. However, implants that are easy to place can easily come out. If you place a small one, it's easy. If you implant a diameter of 4.5 mm or 5 mm, there's not much to trim, and you don't have to shape the bone much, you can just place it. You can cut a diameter of 4 mm or 4.5 mm and implant it. It's easy to plant. But will it last long? The surface area of 6.0 mm and 5.0 mm is almost double. Think about the surface area. It's cylindrical. So the surface area inevitably has to differ by double. There is a huge difference between a diameter of 5 mm and 6 mm. There is also a difference between a diameter of 6 mm and 7 mm. So I routinely use fixtures with diameters of 6.7 mm and 7 mm. That's why I live comfortably. Other than that, there's no other way. That's why everyone pays a lot of attention to drills, and we are making a lot of drills. The reason is that if the kit isn't good, you can't implant wide ones. You absolutely can't implant them. And implants that go in easily come out easily. In the end, bone density is about D1 bone. Then it's really tough. So now we use all sorts of methods. We also use step down and step back. What about D3, D4 bone? You have to apply pressure by continuously retracting the drill. What about the D1 bone? It's hard to cut the D1 bone. You need to use a countersink drill in the middle to cut the crestal bone on top first, and then cut below, continuously cutting until you prepare the implant site with a reamer or drill that is almost similar in size to the implant. If not, the implant won't fit. Absolutely, it won't fit at all. In the case of the initial slock fixture design, there were many wide options. So people often get frustrated because they can't insert it, most of them. But there's no solution. You have to cut it well yourself. And it's not easy to make it easier to insert the implant. It won't last long at all. That's the dilemma. Anyway, that's the situation. Also, for D4 bone and D1 bone, we mainly implant wide, including diameter of 8 mm, even an 8 mm diameter. In the case of D1 bone, if you think about it, you can only implant a diameter of 6.2 mm or in the molars. Then I think it will be possible without too much difficulty. Ultimately, installing fixtures by twisting in screws is called screw-in fixture installation, while just inserting them is referred to as tap-in fixture installation. And if you think about it, healing is the same, whether it's a pressure fit or a loss fit. Will the healing occur as a positional bone growth, or will it be callus bone formation? There are only these two options. So, the shape of the implant and the shape of the implant site matter. So, immediate implants after extraction, those with a wide upper part and those that have absorbed a lot are narrow, right? Then, how will you shape it? Depending on bone quality, D1, D2, D3, D4, a lot of surprisingly difficult things can happen. That's why you need to select the implant well and prepare the implant site well. You have to do the osteotomy very well, and you need to have insight into what size to shape it. There is no definitive answer to this. So some people think that just knowing one or two things will solve the problem. It's absolutely not true, and that's why you're having trouble. They have only used small size implants until now. So if you do one or two drills, it's done. That's hard too. Why? Implants themselves are difficult. But if you want to plant wide, the difficulty level is much higher. But it can't be helped. What happens if you don't plant wide? If you don't plant the big ones, they don't last long. They ask me to teach them something, but I tell them that they need to plant wide and make it last. I can't just teach them an easy way to do it. Such things don't actually exist. And things that are easily planted tend to come out easily. So you can think about that carefully. In the end, this is the situation now. In the case of D1 bone, almost all of it has been cut away. The implant site preparation, meaning the diameter of the osteotomy, is close to the diameter of the implant. However, since the bone is strong, even just a little contact at the end leads to good primary stability. Even just a little contact at the end results in much better primary stability. Ultimately, what fills the gap between these threads? The blood is circulating. When it hardens once, they call it callus. I don't know if it's because some bone particles, the shaved particles or bone powder, are left inside. They call it callus. In the end, this is what becomes bone. Some implant companies say this turns into bone much faster. The reason is that this has been pressed down. So the bone is in a compressed state. Before inserting the implant, a lot of bone isn't shaved. And in the case of D4 bone, compaction occurs as the implant is inserted. This. Then it is called a positional bone growth, where pressure has been applied. Here too, pressure was applied. Wherever pressure was applied, the osteoclast transition defect occurs first, and then the pressured bone gets absorbed. After that, the osteoblast effect follows, or so I've heard. So callus bone formation is when the osteoblasts are activated, but on the side where appositional bone growth occurs, there's also a phase of osteoclasts. First of all, there is a separate osteoblast phase. It's following it. So it's said that it takes longer, but I don't think that's necessarily the case. I really don't think so. Of course, they say that, but in reality, you can't just soak D3 bone or D4 bone like that. You have to inevitably utilize a positional bone growth. D2 bone is half and half. Half is a positional bone growth and half is callus bone formation. It doesn't seem like only one side occurs. Of course, in the case of completely sponge bone, initial fixation is obtained by compression, resulting in bone compaction. So a positional bone growth occurs, but in reality, this is soft bone. In a compressed state, it seems that absorption doesn't happen and it endures. It seems like osteoblastic activity arises directly. Perhaps osteoclastic activity and the osteoclast effect are related to pressure. When too much pressure is applied, the osteoclast effect occurs, but this is originally soft bone. In the case of sponge bone, coarse bone, it seems that even when pressed, it doesn't generate much pressure. This one is vital, and it seems that osteoblasts attach afterwards. That's how I understood it. Since I encounter many cases, I have this concept, so I end up thinking about how to place my implant. And what do I want? Bone healing. The bone needs to heal. New bone must form. So how do the bones react at that time? Whether a bioreactive situation occurs is the factor that determines whether I perform the implant well or not. The product itself, well, it's about the same, to be honest. The surgery is more important. So in the end, it's about callus bone formation and appositional bone growth. But D1 bone is strong because the remaining bones are strong. So here, appositional bone growth and osteoclast effects probably occur first, followed by osteoblasts. These are weak bones. Even when pressed, they don't compress. So it seems like these cells are pressed down and the bone cells have survived. Then it seems like the osteoblasts attach right away. In fact, they attach better than in sponge bone. We connect the abutment and hit it like this. Or we do a lot of one-stage surgeries. We insert the healing abutment. Then about a week later, when we take it out, we hit it like this. When you hit it, you can feel the bone quality as it is. D1 bone gives a very lively sound like bang, 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 while D4 bone, even if it doesn't move, makes a very heavy sound like thud, thud, thud. Sometimes there's no sound at all. So there are times when I doubt if it will attach. Anyway, we wait around 3 to 6 months. For D4 bone, we wait about 6 months. Some people wait up to a year. If you keep hitting it like this after that, it makes a dull sound. The bone around it is all D4 bone, right? But the bone density in the area connected to the implant should be higher. But I don't think that's the case. So for D4 bone, I definitely recommend wide. I absolutely recommend wide. Because when occlusal force is applied, what happens? The occlusal force varies according to the surface area. You can withstand occlusal load in proportion to the surface area. So if you don't use D-bone wide, it's really tough. I've been experiencing a lot of situations where it keeps coming out, which is quite frustrating. Ultimately, while implants are important, the bone's bioreactive balance is also crucial. You need to understand that a certain state of reactive bone is much more important. What most people agree on is that bone cells need to live inside. That's right. So it seems like a diameter of about 0.7 millimeter has been agreed upon. If it's too densely packed, the bone cells inside don't survive well, and the outer part is wide while the inside gradually narrows in a U shape. In the past, it used to be triangular or square, but it's almost concluded that a round shape for the threads is more advantageous. There needs to be a self-understanding of the concepts of D1 bone, D2 bone, D bone, D4 bone, bone compaction, callus bone formation, and appositional bone growth. If it's not this, it's hard to obtain the initial fixation, and after that, you can't properly place the implant. So I see this as one of the really important and difficult tasks. What happens if you dig less underneath, even with the same implant? If you dig less, there might be callus bone formation above and appositional bone growth below. There are cases like this. The cancellous bone is very weak below. Then below, it eventually leads to callus bone formation. Above, there can be appositional bone growth. The buccal part is in contact with cortical bone. Then that will eventually lead to callus bone formation, while there is a lot of cancellous bone on the lingual side. So during placement, the lingual side will be pushed. The fixture, the lingual side will undergo appositional bone growth, and the buccal side will undergo callus bone formation. So many different things are happening. But no one thinks about this. If you apply a uniform approach, every fixture may end up like this or like that. I think appositional bone growth happens or callus bone formation occurs, but I don't think so. It seems that these things happen in a complex manner, not simply. So if you think about these things well, you will probably feel a lot. So you can think this way, and what was ultimately important about the appearance was, I actually think occlusion was more important. In the end, it's about force distribution, that is how you transfer and absorb the force and how you disperse it, right? So the first thing we need to consider is that the worst thing about implants is shear force. You can see how it slips on both sides, right? Exactly. So in the case of chairs or desks, they withstand vertical pressure well, right? But if you push sideways, it moves. That was not good. Shear force was the worst, but you can also see some that withstand with these buttresses. There are buttresses, right? So I think this was not good. The tapered ones do reduce the shear force a bit on the sides, but this reduces the surface area. So it seems that it wasn't good, and similarly, a straight tapered one experiences a lot of shear force. Then the reason why the Astra type gained some attention is that when the bone resorbs, it starts from the crestal area. Right? Generally, since the upper part is in a tapered shape, it seems that the shear force was somewhat reduced. It seems that the initial crestal bone loss was reduced, which led to higher sales. It was recognized as a good implant. However, dual tapered is even better. It can withstand shear force better. I think this is successful. Our dual tapered has been around for 15 years now. So the result is very good. Now, when horizontal pressure is applied, the shear force acts downwards instead, and the sides are all supported by buttresses. So it's okay. This is also fine, and this one isn't bad either. And this one, surface area increases, so it's even better. S-lock serves as a counterbalance. Animals also maintain balance with their bodies. Monkeys use their tails to keep balance. That's right. So what happens when this side gets pressed down? It relies on this side. It acts as a counterbalance, so it seems much more advantageous. This has a very good shape. So if you think about why designs like Jomon pottery or the bisected bronze sword are made that way, you'll understand. So even if the force is received obliquely, it's the same. Counterbalance doesn't work with these kinds, right? But this one has a good counterbalance. When you push here, it can resist that much force. So I think the dual tapered implant had a very certain counterbalance. S-lock, S-shape. This is S-shaped. So we call our implants S-lock. The implant goes in and locks perfectly, and then the S-shape means it has a good counterbalance. So one of the conditions for longevity is because of this. Compared to others, this is much more advantageous. So if you look at it this way, it has significantly reduced the S-shape. In the past, it was more severe. Then it was reduced a lot, and this is our newly released TLX implant. It's similar to BLX and also similar to Adin, and there are various kinds. However, as you can see, there is also a tapered at the bottom, and this body tapered is 4 degrees on both sides. It will be either 3 degrees or 4 degrees. And this is a bit for cutting threads with a CNC, and it is made this way. Because this side needs to be reinforced. It breaks because it becomes too thin. It bends. The implant you've used is like that. Since it's a pin thread, it keeps bending. So I reinforced the inside. As a result, the bit has become like this, and there is also a tapered at the top where the bit is inserted. There is also a tapered inside. Then the bottom part is called spiral cut. Thinking that spiral locking takes place, this also goes up tapered in the same way. So the more you implant, the better the tapered case. With this design, a new design comes out, and the existing design is in an S shape, making it easy to insert, and the threads are hybrid on the top and bottom. The top part is the top, and the bottom part is inverted. It's upside down and made like this, so processing it is extremely difficult. The depths of the upper and lower threads are different, and this bit is also flipped in a mirror form on both sides. So we connect it in the middle. You can't tell just by looking at it. But it's a very challenging implant. There probably aren't any implants that are as difficult to make as this one. The S-lock tapered, S-tapered, and dual tapered implants that we have right now are likely among the most challenging implants to create in the world. We calculated a lot for the counterbalance. Next, we made the tapering dual as well. I don't think there's a design more complicated than this, even looking at other companies. So anyway, it's not easy. So I talked about the overall shape. I don't think there are many people who discuss the overall shape like this, but since I've been doing this for a long time, I wanted to share a bit about this shape. After that, if we cover the thread form, I think today's lecture will be over. I think we will finish talking about the design if we do 2 next week. The thread shape is now important, because the implants you are currently using have extremely thin threads. That makes it easier to insert. So it seems that most older people and women use those implants that are easy to insert. If you look at the screws, there are triangular screws and square screws. Screws like bicon implants are called pin threads. They are not screws. There are shelf type ones and rounded squares. Now, with this we are going to explain, and there are 2 directions. One is planting, that is how will the primary stability be. The other one is what? We need to look at the screw from the perspective of how to distribute the occlusal forces. So the representative one was the triangular screw that was used at first. Then it came to square, and shelf type was also used in the past. This is because bicon implants are unique. Then round ones were used, and now it is trending to use this almost exclusively. So let's talk a little about that. This is the industry standard. It was conventional thread, and then those who want to have mechanical advantages like Karmish argued that they should use square screws. They say it lasts much longer, but in fact that was not the case. Because the space between the threads becomes too deep, and when the bone melts once, it creates dead space inside. So a second infection occurs massively, and it was a disaster. I took out that much. So implantitis occurs enormously. So in engineering, square screws are considered good, but I don't think that's the case here. So now in the recent implants, they have mostly transitioned to U-shaped forms, making one side horizontal and the other side rounded. In the end, stress means that occlusal force is transmitted well. I think the bone volume between the threads was important. What I mean is that when this implant is under force, it will not bear it. The bone bears it. This volume is important. So what about that sharp pin type implant? If you ask about that screw, if it's too sharp, it becomes a cutter and it starts to eat through the bone. So I think that the thickness also has to be at a certain level, and the volume of the bone that can be maintained between the screw threads is more important. And like this, the primary stability is good because there is a lot of bone between the threads. So most of the time this method is used. The pin type is only used for bicon implants and not for others because it gets hammered in. So I think it's probably organized like this. I saw this somewhere in a lecture and I drew it yesterday. There is a program called Illustran. If you draw one by one with that, it can be drawn. So I draw a lot. This is a BioHorizons implant, right? BioHorizons implants do a lot of advertising for this implant. If you look, this is like this downward. The top is in a U shape, but the bottom is tapered and the top is horizontal. It's called laser lock, and as you can see, they promote that by doing surface treatment with a laser here so that the periodontal ligament attaches. Dr. Park has been making a lot of effort to implement this, but it's not feasible in Korea. The laser costs around 2 billion or 3 billion, and they use a cold laser. Moreover, you can't just have one unit. It takes about 2 to 3 minutes to do the surface treatment on one. You need several units. So, is it the AR implant from last time? When I heard the presentation, I thought there was a lot of discussion about this. I think they want to do this, but this is where the soft tissue attaches, right? The fact that the periodontal ligament attaches means that the soft tissue attaches. I don't want that. What's the point if the bone attaches and the soft tissue doesn't? But since they are in periodontics, I guess that's how they think. So if you think about it this way, this is our fishing hook, right? Then here is a triangle, right? I've attached this triangle like this on both sides. Then think about it. The fishing hook is designed so that when the fish bites, it doesn't come off. It holds the force. So if you apply force like this, think about it. This is a buttress. It aligns horizontally. The buttress supports it. Then I flip this over. The triangle remains the same. Where have we seen this a lot? When you go to a campsite, there's that thing you hammer in to secure the tent. And after you hammer it in, well, what should happen? It shouldn't come out. But the force is applied from above. So I think it's been a while, but I believe this was done at ITI Implants. They were advertising SLA. I think they measured how much force is needed to remove it once it's implanted. Those kinds of papers were quite famous back then. But it doesn't make sense logically. How does it receive the force to come out in the mouth? It doesn't make sense. So if you think about it, you can imagine this happening a lot in a butcher shop when they hang meat. When they hang it up, they use things like this. It's secured with a lot of hammering so that it doesn't come out. Anchor. When you do anchoring, you use this. And what happens when it receives force? It goes deeper. This one doesn't go deeper but holds on, right? So the question is, what kind of thread is good? The thread type. So this has become an obvious issue. But most people make it this way because domestic implants are all made like this. Maybe? Why? It's easy to insert. We met once at the lecture hall. Then he looked at me and said that slock has the threads reversed. Inversely, that side is reversed. From what I saw, that side is reversed. Common sense, this is the structure of a durable implant. This is not a long-lasting structure. So most of the recent results have not been good, that company. There are too many failures. The reason is too obvious from our perspective. Easy to insert implants all look like this. What happens if the fastening pin doesn't fit to secure the tent? You'd get frustrated and unable to live with it, right? So in order to resist the pulling force, it fits well and resists the pulling force. But that's not us. It's hard to insert. But it holds up when you chew. So that's why our early implants were successful. It was difficult to insert them. Now it's easier to insert them, but they ask why they lasted so long. It's a completely obvious issue. When I think about it, we feel a lot. Ultimately, this is a triangular screw. They made it shallow in these areas because it's too pointed, right? And they made it square to give a lot of space in between. In my view, this is a good screw, a good implant. It's a good implant. Then square screws also came out, dense screws came out, and these are not good because there's a lot of space in these. So there's a lot of bone between the teeth. Bone thickness comes out, so it can only withstand well. So micro threads were meaningless. That's what I think now. Because they break, they make a lot of thin ones. Manufacturers do. So what happens if you drill the screws deep? They break. So they say having micro threads is good, but that doesn't make sense. This is the early model of biohorizons. This one has been used a lot because in the early days they left a lot of space between the threads. The very first model. This one hasn't fallen out. But what happened to the ones that came out afterward? The screws were too sharp to withstand. This one looks a bit okay. There are also things like this. Do you know how it's made? It's made by pressing with forging. This is called the Tatum implant. There is a company called Tatum Surgical, the person who first performed sinus elevation. I saw that person once when I went to the old AO. I've heard their name a lot because this person has written many papers, especially in the mandible area, regarding gunshot wounds. I think they served in the Vietnam War. So they wrote a lot of papers about reconstructing the titanium here when the patient's teeth were all shot away. They also wrote a lot about Vitalium. I've read quite a few of that person's papers, so I noticed they are also quite short and look very gentle. But how did you manage to perform such bold surgeries? Looking back now, it's somewhat frightening. Is this a Norris implant? There are also things like cortical Norris implants. This design has been widely followed. This is also a one body. What about the one body? It has an internal hex abutment connection. I think this looks better. This is a locking taper. So this is the predecessor of the beacon implant. It seems like the Bicon implant copied this. And next, this is a well-known implant. This one failed and has been discontinued. This also failed and has been discontinued. This one also failed. Only this one survived. Why? It survived because it is a one body. It's not a screw thread, in my view. This is a screw thread that puts a lot of stress. It's hard to insert. So discontinued, discontinued, discontinued. They all have been discontinued. If you look at this, it looks impressive. It's said to be an implant that can be placed with minimal invasiveness. But it seems just like a mixer blade. When stripping occurs, this thread completely grinds down the bone. You may have experienced it. It grinds the bone completely, like a blender. So eventually, only this one survived. But recently, it seems that this one is also not producing good results. So Dr. Kim mentioned recently that everything he implanted has fallen out. Anyway, this is one of the implants that has been talked about a lot these days. Any ridge. They made it in a U shape because they were afraid it would be weak, but it seems like there are many cases where it cannot be inserted because the screw is too sharp. So will the implant preparation match the threads? Or will it match the inner screw hole diameter? Screw hole diameter, will it match the diameter? Or will it match in the middle? This is also a headache. So since they have excavated a lot here, it seems that the first and second threads have all broken. They have broken a lot, and they keep changing and going from any one to any ridge, continuously reducing it. Because if this is thin, it breaks. Then what happens as it keeps breaking? I change the abutment connection from 22 degrees to 15 degrees. That's the situation. This is in the shape of a U. This is a BioHorizons implant. In the past, it was called the Silhouette implant, and that company purchased both BioHorizons implants. So completely different implants became one company. Many implants have a taper shape at the top, like the Astra implant. So there are no threads either. It doesn't work in Korea. Absolutely. It can't work. In Korea, if the margin is visible on the gums, it's a big deal. But this looks completely transparent. That's why that fishing hook-like thing was trying to advertise this. It's horizontal, and it's laser lock. It is surface treated with a laser and such. As you can see here, these things were sold a lot. The problem is, the threads should vary depending on the thickness, but they are all the same. The pitch must be different, but the pitch is all the same. What happens in this case? If you look at it, the screw hole space and the screw thread are only about 1.2 to 1.5 to 1. If the screw thread is 1, the side hole is only 1.5. And the difference between metal and bone creates a strength difference, leading to grade 5. That strength difference would be almost 10 times, which means that all the bones in between will break. So it seems like they all came out. BioHorizons implant. In the screw hole space between, the bone fills in and supports it. However, the IBS implant, on the other hand, has too much, and the screw thread is sharp, so it digs inward. BioHorizons implant has no screw hole space, so all the bones break. It leads to pathologic fractures. So I think that's why it failed. Here there are 3 types of abutment connections. What the BioHorizons implant official said is that 1 connection or 2 connections will fail. It can be helped, because if it gets thinner, the fixture will break, and if it gets thicker, the abutment will break. So they are going with 3 types, and you can see that this is more serious, because there is almost no space between the screws. But it seems they still sell quite a lot. It seems they sell a lot in the US, and they also sell a lot in Kazakhstan at a very high price. They seem to be selling a lot. So I wonder if this is brand power. Anyway, I think this might be a bit of a problem. This is also a BioHorizons implant, and this is also a successful implant. What is this? Swiss Plus implant. This one also bonded well. As you can see, there is enough space in between, and it counters the occlusal force with the buttress well. So I think it lasted long. Next is the one-stage implant. There were fewer problems such as micromobility and initial crestal bone loss at the abutment connection. So I think this was also used a lot. And these are the worst implants. These have no space, and you have to hold something inside. This side is also slippery, shear force occurs, and there is shear force below as well. Then the groove space and the mounting space are 1 to 1. This can't hold up. Why? Because this metal is much stronger. There's something even funnier. There's a screw pitch, but here it's horizontal. So when you turn it, how do you insert it on this side? This is even funnier. Looking at it, the pitches are all different. Is this a double thread? Then I don't know. This is funny too. Here, since it's drilled all the way to the top, it will probably break here. There are a lot of things like that. A famous failed implant is GS2. There are almost no threads. It's opposite. Don't you understand what I'm saying? It's a cylinder type, and since it has a little bit of thread, the bone completely dissolves. It's a failure in design. So all our domestic companies are like this, right? They're upside down. Like the fishing hook I mentioned earlier. It's made like this. It's easy to insert. But it can hold. That's why a lot of them fell out. This is not how it should be. Everyone makes it like this. That can't be right. It's called Alpha Bio Implants, and they make all sorts of things. They put a lot of importance on the threads and developed various things. But since it breaks, they didn't put many screws on the crestal side module. This method works for Westerners because it's long, but it doesn't work well in Korea. If you look, it looks like this. This is not even a screw. So I don't know how it works. This one also has a screw, but it's ambiguous. Yet here there are 3 abutment connections. One connection is a bit difficult, and they made various implants for you to use according to your preference. If you look here, it says ideal for immediate loading, but is this SPI? But there's an elephant sitting here. But does that make sense? It doesn't make sense. So I sketched it out like this. Where does the buttress engage? When it is engaged vertically, when it is engaged obliquely, when it is engaged horizontally. Still, I think this is the best one, this style. Right? Here, it's too horizontal and has a slight round shape at the end, and then this rounded part. I think this is the best, from my experience. So I think we can think this way. If you look at it, the diameter here is about 0.8 mm. Having the groove and the thread about 3:1 seemed good. If the groove is about 3 times larger than the diameter of the thread, I think that was the best of what I've tried. It was easy to insert and seemed to hold up well. S-Lock has this style too. This is the newly released TLX implant design. The threads are a bit sharp, right? And there's a taper shape inside the threads. It's dual tapered, so it won't break, and it seems like it will apply some pressure while being inserted. And then this is called a spiral cut. This has been designed to be more aggressive to ensure good self-tapping. I am currently getting approval, so it will probably be possible to supply it after about a month. It's similar to the IBS implant. It's a more evolved form of implant. In the end, one side has a slight slope and the other side is rounded, as the bit mentioned. This is flipped upside down. So this is one of the implants that's quite difficult to make. With this concept, the top and bottom are designed with a hybrid thread like this. It's easy to insert because it's a double thread. The spiral cut is very active. The apex is flat. There is also a platform switching effect, and various EH abutments can be used. So I think I've conveyed everything about the design so far. This also has approval. This one is a single thread, and there's also a version made with a double thread. Depending on the D4 bone, D3 bone, D2 bone, D bone, I sketched out how to implant it like this. Think more about whether to induce callus bone formation or a positional bone growth. Looking at this, all the triangular screws have been put in like this, until now. It's difficult to insert square screws, because it's square. Does it look a little better, this? The pin thread is hammered in, so there's nothing I can do about it. So I highly recommend a diameter of about 0.7 mm. All are about 0.7 mm, our product. Should I say the screw thread height between the threads? There's enough space, so it's easy to insert because of this, and the new S-Lock seems to last longer. So, as I mentioned earlier, Think about whether to induce callus bone formation or do a positional bone growth while choosing the implant, and you need to perform the surgery according to the characteristics of that implant. And how to distribute the occlusal force ultimately determines the long-term results of the implant. Today I talked about the overall appearance and the screw threads. Next time I will talk about the crestal module and abutment connection. That's all for today. See you next week. Thank you for your hard work.